So in this discussion, we're talking about outpatient CAR T-cell management as presented in the abstract EP1212. So CAR T-cells have now become a standard of care in the treatment of multiply relapsed and refractory acute lymphoblastic leukemia, as well as for aggressive non-Hodgkin lymphoma. There have been two other CAR T-cell studies that have come before the present abstract presentation that showed that this is potentially curative in roughly about 50% of participants or patients that receive a CAR T-cell therapy targeting CD19. The difficulty is that the side effect profile is quite unique compared to a lot of the other traditional chemotherapies, the two of which that are of concern are cytokine release syndrome and neurologic events. Now, these two different things can range in significant severity as well, with cytokine release being the one that happens more acutely, and the neurologic toxicity can happen early as well as late. One of the big difficulties with applying CAR T-cell treatment in a Canadian healthcare system is the resource allocation and the cost. Some of the cost is attributed to the fact that these patients have to be an inpatient for a large chunk of time, and those that have very severe side effects even end up in intensive care, which then of course not only extends their stay in hospital, introduces morbidity, but also then adds back-end cost to not just the upfront cost of the treatment itself. Ideally, if we were able to treat these patients, or some of them anyway, as an outpatient, that would lessen the cost significantly. And the other effect would be to be able to potentially offer the treatment to a greater number of individuals at any given time. So EP1212 is an interesting abstract where they approached an outpatient delivery of a third CD19 CAR T-cell, in this case lisocabtagene maraleucel, or liso-cel for short. Liso-cel is the third of the commercially developed CAR T-cells targeting CD19 that has come up to see whether it has efficacy. Now, there have been multiple abstracts and papers now that have shown that liso-cel is a viable option, but the difference between them, of the ones that are out there presently, is that liso-cel is slightly different in its production process. So while it is a second generation anti-CD19 CAR T-cell, the finished product is in fact enriched with a 1-to-1 ratio of CD4 and CD8 T cells, which does not occur in the other two commercially developed CD19 CAR T cells at this point. The co-stimulatory domains are 4-1BB and CD3 zeta, and the overall transduction process is fairly similar as well. With EP1212, it was an amalgamation of three different clinical trials, Transcend NHL001, as well as Outreach and Pilot. So this is three different studies that allowed for outpatient delivery, and EP1212 is an update of an abstract that the investigators had presented at the Transplantation and Cellular Therapy meeting, or the TCT meeting, earlier this year in February. So to be fair, this is an amalgamation and not an individual clinical trial all on its own. And as a result, it's a mixed population. So for example, two of the studies allowed for CAR T-cells to be delivered after 2 prior lines of therapy, whereas one trial, Pilot, only required 1 prior line of therapy. So therefore, it is a mixed patient population. But despite that fact, it is still useful to be able to get some sense as to what occurred to these patients in an outpatient setting and how viable it was to do in the first place, which can then subsequently inform how we might be able to do it both for standard of care, but also subsequently for additional clinical trials to confirm their results. The criteria for outpatient delivery had to be that the center doing so had a multidisciplinary CAR T-cell team that was capable of handling the toxicities and the monitoring associated with a phase 1 clinical trial, and in particular immunotherapy studies such as CAR T-cells. They had to have constant logistics and communication flow 24 hours and 7 days a week to be able to handle a transition from outpatient to inpatient. Patients themselves had to abide by including safety monitoring education, having a caregiver also go through the education and be watchful over the individual, to stay within 1 hour travel time from the site of care for 30 days post-treatment. So in this update, they expanded the number of people that they present on. So 44 patients with TCT, now 53 patients during EHA. And these 3 studies together focus specifically on aggressive non-Hodgkin lymphoma. While the large majority were diffuse large B-cell lymphoma not otherwise specified, they did include primary mediastinal, high-grade B-cell lymphoma and grade 3B follicular lymphoma. This patient population is about what you would expect. Nearly more 65 years of age or older. Nearly 1/3 were interestingly not at a university-based center. To be fair, some of these were more community-based as opposed to tertiary center-based. There were various risk factors that they tried to include. One of the risk factors associated with cytokine release in particular is tumor burden. Now, how best to measure tumor burden is not entirely clear, or at least there's no consensus at this point. In this amalgamation of 3 studies, so what they took was the cumulative disease surface area, 50 centimeters squared on a CT scan or more. So whether that's a good marker or not is hard to say at this point, but regardless, 1/3 of the patients that were treated as an outpatient met the criteria of their definition for larger tumor burden. Now, cytokine release and neurologic events occurred in 34% and 26% of these patients respectively, but only 2 patients suffered a severe toxicity that required more intensive care, and all of these were reversible. In total, 30 patients, or 57% of the participants, were hospitalized for a median of 5.5 days. 8 patients received the rescue medication tocilizumab for a total of 15%, and as mentioned, 2 patients ended up in intensive care. Despite all of this, their objective response rate in the outpatient cohort was still 81%, which is comparable to the overall trial results of the other 3 studies that were treated, patients that were treated as an inpatient on these 3 studies. The contrast is interesting because if you look at the inpatient arms of these patients, the median duration of admission was 11 days compared to the 5.5 days of the patients that were treated as an outpatient who ended up needing hospital stays altogether. And even then, there's still roughly 40% or more of patients that did not require hospitalization. So from a resource allocation perspective, that's a significant decrease in the number of people not only in hospital, but from the number of days that they had to require to be in hospital if they were needing an admission. But I think it provides a bit of a clear guideline as to how to execute outpatient treatment. And certainly it requires a participation both from the program perspective, but also from the patient and caregiver perspective, as timely recognition and treatment is necessary to keep patients treated in outpatient safe. As we get a little bit better with understanding who is truly a high-risk population, that will likely change as we might be able to cut down the number of outpatients treated to be converted to inpatient. But until that time, I think this serves as a way to at least base on what we can do for outpatient delivery as we start to roll out more and more standard of care CAR T-cell treatments. Ultimately, this is also construct dependent. The CD28 and CD3 zeta second generation CAR T-cell constructs are associated with a higher degree of cytokine release. It is worth noting that comment, though, is technically a cross-trial comparison, so there is potentially for differences in patient populations from that comment. But the feeling overall internationally is that that construct does have a higher degree of toxicity. And so the ability to provide outpatient treatment for those individuals receiving that form of construct will probably have to undergo more stringent guidelines or potentially avoid outpatient delivery altogether. But that's something that will have to remain to be seen as we move forward with this technology. Overall, I think EP1212 was a very interesting abstract and something that is very applicable, particularly in the Canadian healthcare space.